Hello everyone and welcome to this HSJ webinar exploring whether digital technology can help clinicians make safer, more efficient decisions. My name is Claire Reid. I'm a contributor to HSJ and I'm your chair for today's event, which is being run in association with Elsevier. I'm pleased to be joined by Tim Orchard, Chief Executive of Imperial College Healthcare Trust, by James Bird, who's also from Imperial College Healthcare Trust and is Chief Nurse Information Officer, and by Robert Neves, Vice President of Health Informatics at Elsevier. Together, we're going to be discussing the potential challenges of making the right clinical decisions at the right time for the right patient. Every day, clinicians have to make decisions large and small on the most appropriate care for an individual. Those decisions, of course, ultimately determine a patient's experience, the safety and consistency of care, and the efficiency with which healthcare organisations can operate. As the complexity of health needs increases, not least due to the pandemic, the challenge and importance of making the right decision at the right time becomes more significant. So can technology help here? How might digital innovations help clinicians get the right information at the right time, so bolstering safety and efficiency? Those are among the questions we're going to be considering during our discussion today. And for those of you watching live, you can suggest what other areas we might consider. If there is anything you would like to ask the panel, please do submit a question. To do so, just follow the prompts on your screen. I'll bring in thoughts from viewers as the debate progresses, but to answer at the outset one of the questions we're most commonly asked, yes, please don't worry, an on-demand recording of this webinar will be made available in the coming days. Chair's privilege means I'm going to kick off the questions though, and I'd like to start with Tim. Tim, you're the rare example of a Trust Chief Executive who has a clinical background and remains a practicing clinician. Talk to me a little about how you perceive the potential value of digital technology in supporting clinical decision making and what that value represents to you as both a clinician and a Chief Executive.
Thanks, Claire. I think it's a really interesting question, actually. I guess looking at it from my perspective, there are, I suppose, a number of buckets where I think digital technology can help. And some of it is from really just digitizing normal current workflows. Then there's an element of changing workflows and allowing technology to aid decision making. And then there's a bit about collating data, collecting it, and using it sort of after the event. So, for example, I think there's something around accessing data. So we know that even just the implementation of an electronic patient record can allow you to access patients' data remotely, which is really helpful if you're having a conversation with another member of your team about how to manage a patient. It means you can get senior input much more effectively. I think obviously that then moves on to you can then have remote monitoring of patients so that you can then have direct feedback, which again, and I've got colleagues at Imperial who do a lot of remote monitoring actually all over the country to particularly for cardiac monitoring, which allows, again, expert analysis in sort of pretty real time. So there's that bit about accessing data and then analysing it. There's a bit, I think, about digital systems pulling data together from multiple sources to allow clinicians then to make the best possible decisions in real time. We've got a really nice example at Imperial where the system pulls together multiple feeds that alert when a patient may have sepsis. And we saw that by simply the introduction of a relatively straightforward alert, by pulling together vital signs, blood test results, and symptoms, you can increase the proportion of patients getting antibiotics in an hour by about 35%. And actually, we saw a 24% reduction in mortality as a result of the introduction of that simple prompt. So I think there's some really helpful things you can do to aid decision making in real time. If, of course, you then move into the realms of AI and all of that sort of thing, you can then think about how you can improve diagnostics. There's a nice paper about, for example, mammogram reading and how using AI you can potentially dispense with a second mammogram reader. And then finally, I think there's a bit about how can you use technology to allow you to collect data and then use it. So this really appeals to me as the chief executive, as you can imagine. There's a bit about, for example, we have to report in our patients in our lung cancer clinic the proportion of smokers, and it's surprising how frequently we don't directly ask patients and record it whether or not they're smokers. But there's a very nice piece of neurolinguistic programming that's been able to do analysis of the neurolinguistics, which then can pull out the data about whether or not patients are smokers or not. And you can get from a sort of situation of having only 20 or 30% to 90+% data filled. And similarly, we've done some really nice stuff with sort of natural language analysis to look at patient feedback. So obviously you've got the rather blunt tool of the friends and family test in the UK, which is a sort of graded, but actually you can put all of the free text feedback into these sorts of programs, and you can pull out themes. And again, you were talking about patient experience. This is a really good way of using digital platforms to help us to understand patient experience better and then make appropriate adjustments. So I think huge. I mean, basically everything from the very front door right the way through care and out the other end is useful, I think, both to clinicians, but also, as you can see, from a management perspective.
That's incredibly helpful. Thanks, Tim. And absolutely a real suite of areas, it feels like, in which digital technology might be able to make a difference. Your colleague, James, is Chief Nurse Information Officer at the Trust. So obviously, James, you're sort of right at the heart of implementation of the sort of digital technologies that Tim talks about, supporting nursing colleagues in making the most of those kinds of technology and implementing them as effectively as possible. I wonder what your reflections are on the theme that Tim really helpfully built on around what are the types of technology that can make a difference, but equally what makes the biggest difference in implementing them well amongst your nursing and other clinical colleagues.
Thanks very much for that. Yeah, so if I was breaking down to the two parts there, so the what makes technology work really well is when it fits inside the workflow. And having clinicians being key to that design process so that it actually fits well within the workflow. It doesn't create extra work. It doesn't create steps which appear to the clinician to be superfluous or take them off the expected pathway of what the care they were expecting to deliver. So if you've got technology that does that and complements the clinical workflow, inevitably it is easier to embed. You've touched on how to roll that technology out, and that I wish we could say there is a silver bullet of how to roll technology out. And unfortunately, it very much depends on what you're doing. So when we first moved from paper onto our digital health record, we did a piecewise approach, and we took a hospital live every 3 months. And even inside the hospital, we took wards progressively over a series of number of weeks. Different wards went live. But then if we come right up to date, and that was in 2015, if we come right up to date, what we did in COVID, we put a COVID care pathway in, and we went big bang across every hospital in our domain, and there are 7 of them, in one single day, and everyone started using it. So there are big bang approaches, there are incremental approaches, and what makes it sustainable is when we rolled out some of our new care pathway for preoperative surgery to the nursing teams, was the informatics that Tim touched on that support it. So we rolled out an informatics tool alongside the care pathway for preoperative surgery that fed back to the nursing teams how many times the checklists were being done pre-theatre and in theatre on receiving the patient, and how accurately we were recording the nil by mouth for the patients going to theatre as well. And you can really watch the change in practice as that information is fed back to the clinical teams, and they actually see the benefits, both see the benefits of what they're doing, but know that what they're doing is also being tracked and can be monitored.
Absolutely, really helpful, James. Yeah, I think that's an important point, isn't it? Being able to see the value of of both what a clinician is doing and potentially the value that technology is giving in improving things. That's great, thank you. I'm going to come back to a few of the points that you raised and that Tim raised, particularly naturally around COVID and the impact that may have had on potentially accelerating uptake of digital technologies or making them feel even more relevant. But I want to turn first to Robert. Robert, obviously you're from Elsevier, so sort of looking at the supplier perspective, but you've got significant experience as a practicing clinician. I saw you nodding along as James was making that important point about technology slotting into existing pathways rather than feeling different to it. I wonder if you can tell us your view on how technology systems might make a difference to patient safety and your view on organisations and clinicians and users that get the maximum value from such systems. What are the common characteristics there?
I mean, I can't agree more with what's been said already. The key aspect of any technology that's successful, it's really how it's adopted and used by the clinicians. And from that perspective, it has to be of value, right? So it's important that it's integrated into the workflow, like James and Tim, mentioned. It needs to provide a value to me, not just about collecting data, which unfortunately many of the systems become, and the clinicians really have a bad taste in their mouths because it is just considered another task rather than how it can help me as I'm making decisions at the point of care. So we need to look at, when we're designing these solutions, when we're implementing them, we need to look at it from the perspective of the clinician, right? We need to look at it from the perspective of what am I doing every day and how I can add value to that. One area that we see, especially with with COVID and the pandemic, is the aspect of that we need real-time information, the latest information about what's happening. What's the appropriate, medications that you need to be thinking about or using, or what is the latest information about those? That type of information, that type of clinical decision support provided within my workflow, within the technology, really helps me make decisions as I'm taking care of these patients. And it's a valuable aspect of the work that I'm doing. It aids me in my work. So looking at it from that perspective, I think is the critical aspect of really making the systems highly adapted, rather than, like I said, just for gathering of data, which is important for the analysis and the investigations and the reporting. But we need the clinicians to have value there.
Absolutely, well put, Robert. And obviously, you touched on the idea of, again, you emphasised the idea, as others have on this webinar already, of the idea of it needing to slot in, it needing to be a tool, it needing to be an aid to the clinician. In terms of what that means for the way in which we train clinicians, what that means for focus on continuing professional development. I'm going to come to James as well on this, because again, obviously that's a sort of key area that you're involved in. But Robert, what are your thoughts from, as I say, from the supplier perspective about the way in which you are advising trusts or healthcare organisations across the world that you're working with on what you need to be doing to support clinicians to get the maximum value from these tools?
And although I speak, from a vendor perspective, I will speak as a clinician, because that's really what my passion is. My passion is how can we help all of us, right, in the work that we do, the important work that we do. And so, from my perspective as informaticists, right, that's the role that we need to take on, is to look at how do you help design these workflows that are workable, that don't add additional work to the clinicians, and that really help streamline that work effort. And how do you prevent them from having to go to sources of information that's not reputable, right? Google, for example, it's great for when you're searching for something to purchase or that type of thing, but it's not really reliable information, or there's a lot of misinformation, especially in a crisis like this. So how can you bring that information to the clinicians is the key aspect and the key question here. And I believe that that's the role of the informatics team, along with the clinical team, right? We are a liaison between the IT house, the IT department, and the clinicians, to be able to translate But clinicians need to take the responsibility on to say these are our needs and identify our needs, and work with the informatics teams and your IT teams to really come up with solutions that really work for them. And I like to think about it from the standpoint of that every workflow that we do can be supported by good information, by good workflows, by efficient workflows, and really make them clinical decision support tools if we look at them from that perspective and not just to replicate a workflow that exists in an organization. I think that's the biggest paradigm shift when we're looking at designing systems. It's looking at these workflows. Why are we doing them? How are we doing them? And can they lend that value to the clinician at the point of care?
That's great. Thanks, Robert. James, I'm going to come to you on this same question, probably to you afterwards, Tim. We've got some audience questions in already as well, which I'm keen to get to. A reminder to anyone, if you are watching live and you have a question you'd like to put to the panel, do put it forward. Just follow the prompts on your screen. James, first off, though, just a few further reflections, I suppose, on that point around if we assume that every clinician now is working in a digital world and is working with digital tools that are hopefully going to help them do their job better. What does that mean for the way in which we are training clinicians, for the way in which we are supporting clinicians through their career as new digital solutions become available? And what are your reflections on that as CNIO?
Cheers, thanks. I think you'll be aware. I mean, there was a paper many years ago from the RCN, Every Nurse and E-Nurse, which was talked about this and the challenges about all of a sudden it has changed from a data being a particular unique specialty off to one side and only interesting a few people to going forward, as you rightly say, electronic patient records are a core staple of now what we do. It is the way patient data is recorded, and we expect everyone to interact with them. And people will interact with that at different levels, and that's completely right. There's going to have to be a way or an approach that we train people over the next probably 10, 15, 20 years in how to utilize the data we're putting in a meaningful way to then better their patient care. Now, some of that might develop itself by when we have new young graduates coming through who've only ever known things on computer, who are therefore much more au fait with navigating around a computer resource to get what they need and what they want to improve patient care. They will probably find that very easy. For those of us that started on plain film x-rays, that might be a little bit more of a journey. But I think over the course of time, this will become as natural to the clinician and the nurse as being on paper did.
That's great. Thanks, Robert. Tim, did you want to come in on that idea of what it means for the way in which we train and support staff before I ask you my next question?
Yeah, no, I mean, I think James has summarised it very nicely. I think that if you're like me, and I consider myself a complete Luddite in this regard, someone plonks a new computer system down, and you desperately want to just do what you were doing, but possibly on a computer. And I do think there is a really interesting question about how do you engage with clinical staff to make them take this up. And I think we've done quite well, I think, but as James would attest, we still have a proportion of consultants, doctors and possibly even nurses, I don't know, who tend to use the electronic patient record as if it were a piece of paper. And so that training around how you get the most out of your data and how you record your data in the best way, I think is really important. But I think we've also, acknowledging the fact that a lot of clinicians they're like sort of people who, if they were building a chair or a wardrobe from IKEA, wouldn't look at the instructions to start with, and then they'd end up with an Allen key and a couple of spare screws at the end of it. And so I think one of the things that we've done is, and I think it's been quite effective, is when we've introduced a new change, is to get a lot of floor walkers who can actually support clinicians in real time to help them to understand as they're working through in real life what the benefits are and how they can get the most out of the system. I mean, I think the other thing we do have to do is absolutely train a generation of young healthcare professionals who are absolutely focused on how they can get the most out of data. And if you're starting a clinical research project or any sort of service evaluation now, then understanding what data is available to you and how you can best use that is absolutely key.
That's great. Thanks, Tim. I was always under the impression that if you had at least 5 screws left at the end of building an IKEA product, you've done it right. But apparently you're implying that. I need to rethink my life and most of my furniture.
Absolutely.
Tim, the other point I wanted to make to you talked really helpfully at the outset about a huge tranche of things that Imperial are doing around generally this idea of supporting clinicians to make the right decisions at the right time. From traditional clinical decision support to stuff on patient experience to, sepsis, assessment tools and so on. I'm interested from your unique, I think fairly unique perspective, obviously, as chief exec and practicing clinician, about business cases around that, because something that we often hear is it's difficult to prove the value of this sort of support for clinicians or of IT systems more generally. I'm interested in your thoughts on that, whether it does make a difference that you've got that clinical sort of string to your bow, and indeed, whether COVID changes that. Has COVID meant that we now just have a much clearer argument because we've just got on and done it and we've realised that these things do make a difference?
Yeah, I think they're really good questions. I mean, they're really horrible questions in the sense of they're really difficult to answer, but they're good questions. I think it's certainly in the NHS, we are sitting in a situation where our capital budgets are really tightly constrained, and certainly in the organisation that I work in, we have real estates issues that gobble up large proportions of capital. So the amount that you have left to invest in systems is smaller than you would like it to be. I think that. I think it would be rather arrogant to assume that being a doctor means that you have a sort of unique perspective on these things. I'm not sure that you do. I mean, I think you can understand how it's been personally useful for you, and you've been on that journey of being, slightly skeptical to actually really understanding how useful it is to be able to access your patient's information in real time and in different places. So I think there is that you can understand something of the utility, I guess, that perhaps. Not everyone can, but I don't think you have a unique perspective. I think you're absolutely right about COVID. I mean, and one of the key things, for example, is digitization of outpatient appointments and virtual outpatients, which I think we had been doing, but in a rather pedestrian way for a long period of time. And suddenly, like that, overnight, you've got 90% of your appointments suddenly being virtual. And of course, suddenly everybody realizes the value. And of course, there's value to the organization. Actually, it's interesting that virtual appointments tend, I think, to be slightly shorter than in-face appointments. Interestingly, I think part of that could be you always feel guilty if you've kept someone waiting for an hour in outpatients to see them and they come in and you actually only need to have a 5-minute conversation. You sort of think, I can't just turf them out. I've got to keep going for at least 10 minutes. Whereas actually, I think, it's much more convenient. And I look after patients who have long-term conditions. And rather than dragging them up to the outpatients, the fact that they can have a virtual appointment, which means they can just step away from what they're doing for a few minutes and then step back into it. I mean, it is a huge convenience for them. And actually, in terms of patient productivity, their own personal and societal productivity, there's a huge advantage there. So I think we are going to have to look at these things in a different way. I also think, of course, the interesting thing, again, from a health and NHS perspective, is the financial regime has completely been turned on its head as a result of COVID, in terms of moving from the cost and volume model. And as we move into integrated care systems, I do think we will start to look at these business cases in a different way, because if there is a clear benefit to the healthcare system, and a lot of these things do have that sort of system benefit rather than an institutional benefit, or just an institutional benefit, then I think a lot more of these cases will find it easier to get through.
That's great. Thanks, Tim. I saw Robert nodding along during that. I'm going to want to come to you, Robert, to comment on that, but also I want to just add, I suppose, one of the questions that has come in from the audience. Louise, although she admits it's a comment rather than a question, the classic line whenever questions are asked at a conference. She says very sensibly, we have so many platforms and systems and many that do not interact with each other, so we find ourselves impeded in everyday tasks. And in the world of integrated care, we host staff on our sites who cannot access everyday clinical systems without jumping through hoops. This needs to be made universally easier to maneuver. So, Robert, I suppose two things. Build on Tim's reflection just now, but also talk to us again, I suppose, coming from that supplier perspective, of this ongoing challenge of interoperability and how we can make sure that clinical decision support just slots seamlessly into lots of other systems.
Yeah, that's a really good question and a big challenge, and it's been one for many years. Let me start with following Tim in the first point, because of the cost and the effects of the pandemic. Actually, I'm actually working with a client right now in Latin America, and they provided some data which we found really interesting, with a core set of patients that they took care of because the cost was astronomical, COVID patients, as to what they budgeted. And what we found was one of the areas that we saw was an over ordering, if you will, of vancomycin levels. Right now, you can look at this and say, well, during the time period that this was occurring, right, we can understand why clinicians were ordering what they were ordering, right? But what we found was that there was a 50% over ordering of vancomycin levels, where it didn't even make sense clinically to order a level of this type, right? Now, the great thing about systems is that it's collecting this information that you can analyze, and then you can do and hopefully put in something to help support that, right? To bring down that over ordering, if you will, and that's what we're working on with them, reducing that and putting in a process in place in their everyday workflow, right? But that's the beauty of this, right? That you can take their time to analyze. I think the big mistake that many organizations make is that they don't take the time to analyze the information that they're gathering in their own systems and use them to help improve their processes. So that's one thing, and it's one example that I just recently, I'm talking about as of 2 weeks ago, that I've come across as we've done this analysis. The other thing is that sometimes in a crisis like this, right, we tend to forget our what the normal practices are. And sometimes you just need a reminder to say, we're operating under extraordinary circumstances, but the practice doesn't change, right? We should, there's things that are consistent. So that's the other aspect of it. When it comes to this issue of, having multiple systems to work through and the inefficiencies that it provides, I will say that from personal experience, having worked as a clinician in areas like this, and having to use multiple systems, as well as an informaticist in trying to clean up these things, right? That it's important that we, as organizations, that we look at this and we look at how do you streamline it in the best possible way, even though you may have to have multiple systems for whatever reason. There's, it could be from a reimbursement perspective, a compliance perspective, et cetera. But we should never accept the status quo with them. There is ways of streamlining and achieving more efficiencies so that we don't drive the clinicians crazy. I worked at an organization where the clinician, during an intra procedure, they had to document in 5 different systems because of reporting and all these things. And we spent a good 6 months and we reduced it to 2 systems, right? Better than 5, still 2. However, it can be done. The thing is that you sometimes have to, how we say in America, kill a lot of sacred cows, right? And really make decisions around that aspect of it. But if if you support that to your organization and say, hey, we're going to still be able to create these reports, do this, while we reduce these things, it will help tremendously. But it does take that, that foresight and that thought process. And I don't want to keep speaking for informaticists, but that's really what a key role is from our perspective, to be able to do that and help those clinicians. But my biggest words of advice is don't accept the status quo. Talk to your IT teams, talk to your informaticists, and bring together a team that can look at this and streamline it from that perspective. And this is outside of vendor advice, right? I mean, I never want to add burden to a clinician as a vendor for sure, because they're going to end up dissatisfied in the end.
Absolutely. Thanks, Robert. More audience questions, and these sort of tie in, I suppose, to the point, Robert, you were just making about the importance of building trust and understanding between informatics colleagues and clinical colleagues, but also, I think, speak to some extent to the shift we were talking about earlier about greater use of digital as a part of day-to-day clinical practice. I'm going to sort of put them together as one question, but I'm going to start with James and then come to you, Tim, if I may. So, first off, and this was specifically to you, James, from Michael, who's a consultant cardiologist and CCIO. He says, I'm interested to know from James how the use of particular pathways is actually enforced. You touched earlier, James, on the idea of the importance of pathways and the ways in which technology can help with that. My experience is that clinicians are very good at finding workarounds to avoid using pathways. So that's the first point that I'll come to you on, James. And then in a moment, Tim, I'll come to you. You may want to reflect on that, but you may also want to reflect on this one, which is comment on the value of prescribing algorithms from the clinician's point of view as well as the patient. Computer says prescribe so-and-so. Will it really change clinicians' gut feeling on best treatment? James, can I come to you first? Reflect on either or both of those, if you would.
It's very interesting of how do you encourage the good practice and discourage bad practice. I think it's safe to say that however well intentioned your design for your care pathway is, someone will always go off of it, and that's fine, because you're not going to capture 100% necessarily. What we did is we had a very, very quick fail cycle. So it failed, we replaced it, we went live with the COVID pathway. 2 days later, we went live with version 2, because whilst sitting in a room with my consultant colleagues, we'd come up with an ideal solution. It didn't survive contact when we went out onto the shop floor. So the ability to turn around those very quick, that didn't work, that didn't behave quite how we thought it would, turn that round, make that change. The other thing we've done is we always do a process by which we go through and say, actually, what is the easiest way, or what is the shortcut? So we go through and try and break it as clinicians working in IT to find the shortcut so that we know it, and we should design it with that shortcut in mind. Because actually, if there is a quicker or a shortcutted way that doesn't quite do the same thing, people, as you say, will find it. So I think if you put a lot of careful design into that side of it, you certainly end up getting what you want out the other side. People will still come off pathway, and that's when you then, so effectively you almost, I don't like to use this term carrot and stick, but you've got the behavioural nudge side where I'm trying to make you follow a pathway because actually it's the right thing for this patient based on the data that you've entered, etc. And this is what we think is the right treatment for this pathway based on national guidelines, etc. And then actually, if you choose to not follow it, that actually might also be the correct thing. So we need to acknowledge the fact that pathways don't cover absolutely everything, and acknowledging the fact there'll be elements when patients will come off pathways, and that is completely correct. But actually feeding that back to clinicians and nursing staff and go, actually, these 6 patients came off the pathway, and actually, did they correctly come off the pathway? That feedback loop sometimes is good, both from the pathway development to realize actually there was a reason or something we need to add into the pathway to account for that reason why people should move off it, or as feedback to the individual clinician or nurse to go, actually, okay, I didn't realize I was supposed to, for that reason, carry on the pathway. With regards to the medications, we've had quite a lot of success with what our EPR provider calls power plans, but effectively they are prescribing care sets. And certainly we had them set up for COVID. And do people follow them? When the comment about the computer says no, things, in the general state, yes, because it physically makes them easier. It is less clicks to get to what you want. You don't have to look up the antibiotic guidelines for X. So for the COVID pathway, when we started running out of drugs halfway through April, we were able to switch the pathway and switch the entire hospital's administration of a certain med to a different med overnight to account for a pharmacy disruption. And that is the sort of level of, yes, I know you were using this yesterday, tomorrow you're going to be using that, and we can switch you back when we've got the right supply. So we found people do engage with it because it is easier for the clinician and the prescriber.
That's great. Thanks, James. I want to turn to Tim on that as well, and your thoughts about, I suppose it's this classic thing, isn't it, of if you give me a calculator, it doesn't make me a mathematician. There is a real element of clinical judgment that is important and we mustn't lose sight of even when we have these tools. So I'd like to ask you about that first. The second thing, a question from the audience, which I'm going to quickly sneak in, from Helen, is about the potential of real-time digital clinical data to be used at an organisational level, such as ward directorate, hospital-wide, to, for example, redirect resources, staff expertise, etc., to areas of highest need. So talk to us about that as well. First, on that point around clinical judgment and potential for.
So I think James has summarised it very nicely. I think James has summarised it very nicely. There's a bit, isn't there, about making sure that you've got good clinical engagement in setting up the pathway in the first place, because that's the most likely way that you're going to get people to follow it. But I think both in terms of care pathways and actually in terms of prescribing, one of the key things here, I think both in terms of improving patient outcomes, is about eliminating unwarranted variation. So and I think that, as James said earlier, one of the key tools we have is playing back to clinicians what they've done and how that compares to what you would expect them to have done. And I think you're absolutely right. And and again, I work in a specialty. I'm a gastroenterologist with an interest in inflammatory bowel disease, and there are some areas there where they're relatively evidence-free. And so, I would feel very miffed, I think, if people were telling me too closely what to do in areas where I think they're absolutely right, clinical judgment is required. But I think what this playing back of data allows is you can say, okay, I followed the guidance in terms of the prescribing algorithm 80% of the time. And actually, if you look at the 20%, there are really good reasons why I didn't. If, on the other hand, you think, well, actually, I only followed them 50% of the time, and actually the other 50%, I did things that were almost completely random, then that gives you the opportunity to reflect on whether you should perhaps be really focusing on those things. So I do think there's that bit about really collecting the data and then using it to feed back to individual clinicians and groups of clinicians about how their practice varies from what would be regarded as best practice. And I think that then drives people to, and doctors are ultimately extremely competitive individuals, and it drives them to try and make sure that they absolutely do the best thing. I've immediately forgotten the question that you asked me from Helen, which was...
don't worry at all, Tim. So it was around, it's to some extent connected, actually, around the potential of real-time digital clinical data to be used at an organisational level or to actually make decisions about resourcing.
I think it's potentially really helpful. I mean, we started a little bit on the journey to this with a sort of control center idea. So, for example, we know the number of ambulances that are coming through to our emergency department, the news scores of all the patients that are in our emergency department at any given time, so that we can have an assessment about how risky, what level of clinical risk we're carrying in the ED. And that's on us. So we have a set of screens, one that shows us the inpatient bed base, that shows us the number of free beds, looks at staffing and stuff. So there is that opportunity. Honestly, I don't think we probably have got the full potential out of it, but I think that we've certainly moved away from what we were doing up until scarily recently, which was somebody walking around with a piece of paper and a clipboard, counting the number of empty beds 3 times a day. That's obviously been a huge help. But I think there is huge potential to use that in an even more effective way for the daily operational running of the trust.
Absolutely. Thanks, Tim. We are unbelievably coming almost to the end of our time. Before I start to wrap up, I wonder if I can ask each of our panelists for, I suppose, that the one thing that they think is most important for people to be thinking about when it comes to digital technology's ability to help clinicians potentially be making these safer and more efficient decisions. And I'm going to be strict, everyone. I'm going to ask you just for 2 or 3 sentences, if I could, to keep us on time. Robert, can I start with you?
I think my biggest advice as an informaticist is that keep in mind that clinicians just want to know the why, right? And provide them that information. Sometimes we want the technology to taser us, to remind us not to do something and change that behavior that way. And that doesn't work for us, right? It doesn't work for anyone. If you provide them with a why, most of the time that'll reduce, have a great effect. Then you can use your alerting in a much more judicious way rather than relying on alerting to change behaviors. So be really judicious and careful about, providing the necessary information so that the clinician can make the decisions on their own. And then you use the added functionalities, the added technology to help with some reminders where there needs to be. I think that's my biggest advice as an informaticist.
That's great. Thanks so much, Robert. James, can I come to you next?
Yeah, so I suppose my one piece of advice is don't try and build the 100% solution. I think you have to go live with something, and we all too often let perfect become the enemy of good. And I think we should sometimes, like we went live with the COVID care pathway and then put the second one live 2 days later. Sometimes you just need to quickly innovate, and I don't think sometimes we do that quick enough. So I think it's about being prepared to put it live, use it, realize it doesn't work, and go again.
Absolutely. Thanks, James. It's interesting, isn't it, the way that COVID really has changed that maybe feeling very risk averse or whatever, of a feeling of we just need to get on and do it and see what happens. It'll be interesting to see whether that's a mindset that can remain as we continue on. Tim, what's your final point you'd like to make to sum up on this topic?
A very boring one, really, I think, which is you have to make it useful to the clinician. That's the ultimate key here, is that it has to enhance what the clinician is doing. And I guess I would add into that, it needs to provide some sort of analytic function that can play back to the clinician to allow them to understand sort of how they're doing.
Not boring at all, Tim. I think a really important point. Thank you for making it. As I say, I'm amazed to say that our time is up. I found it a really interesting discussion, and for me, it's just zipped by. I really do feel it's made clear the potential that digital technology has to support clinicians in all manner of ways. I think it was really interesting when Tim at the beginning spoke about that whole tranche of things that was happening in Imperial that really was speaking to that central aim. We could certainly continue the conversation for longer, but unfortunately it is now time to draw things to a close. I really can't do so without thanking our panelists for their generosity with their time and their expertise. So thanks to you, James Bird, Robert Neves and Tim Orchard, as well as, of course, thanks to Elsevier for supporting today's event, and to all of you for viewing the webinar. I really hope you found it an interesting and useful discussion. Goodbye for now.